All right, I'll be doing some quick reviews of neurology. These will be rather short and less detailed than some of the other lectures, but it will provide sort of highlights of different areas of neurology. So our first one is going to be on localization. And so the big picture, and localization is really important in neurology. Most neurologists, when we see a new patient, that's the first thing we need to determine. Where is the lesion? So someone comes into the emergency room with weakness, for example. Well, the lesion could be cortical, subcortical, brainstem, spinal cord, anterior horn cell, nerve root and cauda equina, plexus, peripheral nerve, neuromuscular junction, and muscle. And so just something basic like weakness, the problem can really be widely distributed throughout what we call the neuroaxis. And so why is it important? Well, do we need to image the brain? Do we need to image the spinal cord? Do we need an EMG to evaluate the peripheral nerves? Or do we need to be looking, in the muscle, maybe with a muscle biopsy or something like that? So it really is the first question that we need to ask when we see a new patient. Where is the lesion? And so I'm going to focus on weakness in this lecture because it's a good way to illustrate here the neuroaxis from the cortex all the way down through muscle. I put an asterisk by two areas here of the neuroaxis where we really don't get weakness. The basal ganglia are subcortical neuronal structures, and diseases or lesions there don't produce weakness, but rather a movement disorder. So tremor, like Parkinson's disease or some other choreiform movement. Likewise, lesions of the spinal cord or of the cerebellum or degenerative process of the cerebellum doesn't result in weakness, but rather ataxia and some other problems that we'll talk about. So those are a little bit exceptions here, but otherwise everything else here, any lesion can give a patient weakness. So let's start with that. And we'll see there are really four possibilities when someone comes in with weakness. So the first one is, are we seeing upper motor neuron findings? And in a bit I'll list upper motor neuron findings, what those are, but if we do have upper motor neuron findings, you have three options. The lesion is either in the brain, in the brainstem, or in the spinal cord, because those are where the upper motor neuron pathways travel. Now, like everything, there are some exceptions to this. So some things like serotonin syndrome, we can get some upper motor neuron findings. But in general, if we have upper motor neuron findings, our lesion is in one of these three places. So we either need to look at the brain and brainstem with an MRI or perhaps CT, or we need to image the spinal cord. All right, if we have lower motor neuron findings, and again I'll list those here in just a minute, then our options are either, well, first of all, what is a lower motor neuron? A lower motor neuron is a neuron that talks directly to muscle. And so those can originate from the brainstem, so our cranial nerve nuclei. Let's just think about cranial nerve 12, which goes directly to the tongue. So that's a lower motor neuron. So we have certain cranial nerves, cranial nerve nuclei that supply facial and other cranial nerve musculature. Those are lower motor neurons. And we have the anterior horn cells, which travel throughout the entire spinal cord and are the neurons that supply muscles in your arms and legs. So these are the lower motor neurons. Okay, and from there, the projections with regards to the anterior horn cell, we have nerve roots and plexus, and these continue on as peripheral nerves. So if we're finding that the weakness has lots of lower motor neuron findings, we need to look in this distribution, okay? Not brainstem or spinal cord, but this would be the neuroanatomy of a lower motor neuron lesion. Now, if the patient does not have upper or lower motor neuron findings, but instead the weakness consists mainly of a fatiguing weakness, so they may be initially strong, but then they get weaker as you keep checking, well, that would be classic for a neuromuscular junction lesion or disease process, like myasthenia gravis or Lambert-Eaton syndrome. Okay, and then finally, if the weakness is not upper or lower motor neuron, it's not fatiguing, and it mainly involves proximal muscles, now we're dealing with a muscle disease. All right, so weakness, really, this is a very basic outline, but generally when we have a weak patient, just real quick, we need to know, are there upper or lower motor neuron findings? Is it fatiguing weakness, or is there proximal muscle weakness? And so let's go through each of these now and just add another layer of detail. So if our lesion is in the brain, then in general patients are going to have contralateral motor, sensory, and visual deficits. Okay, so that would be contralateral face, arm, and leg, motor and sensory loss, or a contralateral visual field deficit. So if the lesion is in the right hemisphere, the patient will have a left-sided visual defect of some sort. All right, obviously much more could be said here, but if we're dealing with the dominant hemisphere, then patients will frequently have an aphasia. If we're dealing with the non-dominant hemisphere, patients will have anosognosia, and a whole bunch of things fall under that. But anosognosia is denial of illness. So the patient is unaware that they have a problem. And so there are, again, some other things that go along with that. So again, just looking at the brain, so here's our primary motor and sensory cortex. So if we have a lesion involving that, the patient will have contralateral weakness and sensory loss. These two generally go together with the lesion here in the hemisphere. We'll talk about lesions that involve the frontal eye fields and prefrontal cortex as we go on. And of course, if we have a lesion back here involving visual cortex, the patient will have contralateral visual deficits. And here we're looking at the language dominant hemisphere. So we have Wernicke's area and Broca's area. So if it's generally a left hemisphere lesion, the patient will have an aphasia. Now, if our lesion is brainstem, so again, we're in the upper motor neuron category here. Brainstem lesions have a very classic feature, which is patients have ipsilateral cranial nerve deficits and contralateral deficits in the extremities or in the arm and leg. And that is the rule of thumb really for all brainstem lesions. And so let's just give one example, which is medial medullary syndrome. All right, so here's the medulla, pons, and midbrain, and here we have the cranial nerve 12 nuclei. All right, and traveling through the medial medulla, we have a very important upper motor neuron pathway here, the cortical spinal tract. All right, so if our lesion's in the medial medulla, the patient will have contralateral upper motor neuron findings, weakness on the opposite side of the body. And in green here, we have a very important sensory pathway for vibration and proprioception. Travels up the posterior columns, becomes the medial lemniscus. And so notice with a small lesion here in the medial medulla, okay, due to a stroke in the distribution of the anterior spinal artery, the patient will have ipsilateral cranial nerve deficits. Okay, so in this case, the lesion is on the left, and so the patient has a left hypoglossal neuropathy. The tongue's going to deviate to the left. So that's your ipsilateral cranial nerve deficit, but they're going to have contralateral deficits in the arms, opposite arm and leg, with weakness and sensory loss. So again, every brainstem lesion we can put in here is generally going to have that rule of thumb. So cranial nerves don't cross. The only exception is 4, and that really is not clinically significant at all. So when we think about lesions of cranial nerves, the deficits are always going to be on the same side, right? But these pathways, look at how low they cross, motor and sensory pathways here. So if we have a lesion anywhere that affect these pathways in the brainstem, in the arms and legs, it's always going to be on the opposite side. All right, so that's our rule of thumb for brainstem lesions. Now in the spinal cord, again, lots of upper motor neuron findings. Okay, the rule of thumb here is that when we involve the spinal cord, the nerve roots are right adjacent. They come out of the spinal cord. So we're going to get focal nerve root involvement, and we're going to have weakness and sensory loss below the level of the lesion. So all of these descending motor and ascending sensory pathways, wherever you put the lesion in the spinal cord, your deficits then are always going to be immediately below the level of the lesion. And if we involve one half of the spinal cord, we'll get something called the Brown-Séquard syndrome, which I'll talk about later. And spinal cord lesions classically result in bowel and bladder dysfunction as kind of a unique feature. All right, so here's the spinal cord. And so we can see the nerve roots here, sensory and motor, coming right out of the spinal cord. And so here we have a patient with an obvious cord compression. All right, so let's just say this is C5. And so if we have a C5 disc or something compressing right here, well, we're going to have focal deficits involving these motor and sensory nerve roots. So we'll have sensory loss in the arm in a C5, maybe a C6 distribution. That's our focal root involvement. Okay, but the compression here on the spinal cord, which we can see is really significant, is going to result in motor and sensory loss below the level of the lesion. Okay, so that focal nerve root and then involvement of all motor and sensory below the level of the lesion is classic then for a spinal cord lesion. And spinal cord lesions we call a myelopathy, in this case a cervical myelopathy, and they generally go along with a focal radiculopathy. Radiculopathy describes the nerve root involvement. All right, now if we have problems with cranial nerve nuclei in the brainstem or with anterior horn cells, these patients classically have atrophy and fasciculations. Now, here we're kind of giving away our lower motor neuron findings, but fasciculations in particular are a hallmark feature, especially for anterior horn cell diseases. And so we'll talk about ALS, where amyotrophic lateral sclerosis or Lou Gehrig's disease, where patients have lots of fasciculations. And just think of these cranial nerves that talk to muscles as kind of fancy, specialized anterior horn cells. So, for example, the hypoglossal nucleus, that also degenerates in ALS. And so in that case, the patient will have atrophy and fasciculations of the tongue. All right, next, nerve roots and plexus. So again, we're in a lower motor neuron category here. And so lesions of the nerve roots and plexus tend to be painful. And we call that radicular pain. Radicular, this means nerve roots. So radiculopathies are much more common than plexopathies, but patients will have neck or low back pain that radiates like an electrical pain down the arm or leg, and there will be focal weakness and sensory loss and focal loss of reflexes depending on what part of the roots or plexus are involved. All right, so if we just look at the cervical nerve roots and plexus, okay, here are the roots coming out of the spinal cord. So again, this is very common in the cervical area. C7 radiculopathies are very common. So patients are going to have neck pain and they're going to have shooting pain that goes down the arm. And so they're going to have focal weakness, sensory loss, and reflex changes, those three things, depending on what root is involved. Likewise for plexus lesions. So when we think about the plexus, it's important to remember that when the arms are at the side, the clavicle overlies the divisions. All right, so above this we have trunks, below it we have cords. All right, so here's our brachial plexus. And so oftentimes these may be traumatic. Maybe the patient has a clavicle fracture. And then just like with radiculopathies, let's say our lesion is maybe here of the inferior trunk. Well, the patient is going to have focal weakness, sensory loss, and reflex changes in that distribution. Okay, and our last lower motor neuron category here are peripheral nerve lesions. And so the classic feature of a peripheral nerve problem is stocking glove sensory and motor deficits. So neuropathies are what we call length dependent. So the longest nerves are affected first. So symptoms generally start in the toes and spread up, and then later involve the fingertips and work more proximally. All right, so we're going to have distal sensory loss and weakness, and we'll have loss of reflexes. And early on that involves the most distal reflex, generally the Achilles reflex, But if we have an acute peripheral neuropathy like Guillain-Barré syndrome, these patients will have loss of all reflexes. Okay, so if you see something like this, it's distal sensory loss working its way up, distal in the hand. This is stocking glove. And so now our lesion has to be of the peripheral nerves. All right, looking at the neuromuscular junction. So again, fatiguing weakness is the key feature here. And so I just want to emphasize that neuromuscular junction pathology, we get no upper or lower motor neuron findings. Sensation is normal because we're just dealing with a problem at the neuromuscular junction. It has nothing to do with sensation. But neuromuscular junction lesions are characterized usually by quite profound ocular and bulbar weakness. So ocular involves the eyes, droopy eyelids, double vision, difficulty moving the eyes, and bulbar refers to dysarthria and dysphagia. So those are generally quite prominent in neuromuscular junction conditions. Again, think myasthenia gravis or Lambert-Eaton syndrome or botulism. Okay, and then patients certainly do frequently have extremity weakness as well, but the ocular and bulbar tends to be quite prominent. Right, so someone with a neuromuscular junction problem like myasthenia will often come in most likely with initially some ocular problems like a ptosis. All right, and then finally in our muscle category, so again, these are patients presenting with proximal muscle weakness. They have no upper motor neuron findings, no lower motor neuron findings, and it's not fatiguing weakness. And just like neuromuscular junction lesions, these patients also have normal sensation by and large. All right, so what does proximal muscle weakness look like? Well, you need the proximal muscles in your legs to climb stairs, so patients will complain of difficulty doing that, or lifting your arms above your head. So, getting something out of the cupboard or something like that will be difficult with proximal weakness. And a very kind of unique feature, it's not specific for this condition, but it's kind of classic for Duchenne's muscular dystrophy, the severe proximal muscle weakness. Here, these children, if you ask them to rise from the floor, their distal muscles, especially plantar flexion, is quite strong. So they will stand up on their tiptoes, and then they will walk up their legs using their arms and proximal muscles here to kind of inch up the thighs here to stand up. And so this unique way of standing suggests severe proximal muscle weakness and is called the Gowers sign. It can be seen with a variety of muscle diseases, but most commonly Duchenne's muscular dystrophy. All right, so what do we mean by upper and lower motor neuron findings? So this would be a very high yield, important thing to remember here. Upper motor neuron lesions produce abnormally brisk reflexes. Right? So we have hyperreflexia, and along with that, we generally see clonus as well. That's usually checked routinely in the lower extremities, but we can check that easily at the wrist in the upper extremity as well. In the lower extremities, we have a Babinski sign, better referred to as the extensor plantar response. So you strike the bottom of the foot, usually with the back of your reflex hammer, and the big toe goes up. So that is an upper motor neuron finding. Okay, in lower motor neuron conditions, reflexes go away. Again, think of something like Guillain-Barré syndrome, which affects all the peripheral nerves. And so there we have an absent loss of reflexes. Toe goes down in something lower motor neuron, which is normal. But this is really the abnormal one if we see an upgoing toe. In terms of tone and weakness, these two kind of go together. Our muscle tone is increased in upper motor neuron lesions, so we call that a spastic weakness, kind of a stiff, rigid type weakness. Whereas in lower motor neuron conditions, we have a floppy, decreased tone, and so we call it a flaccid weakness. Now, if someone has had weakness for a period of time, if it's lower motor neuron, there's going to be significant atrophy. So again, think of some of those lower motor neuron conditions we just mentioned, like amyotrophic lateral sclerosis, okay, where there's quite profound atrophy. Whereas an upper motor neuron lesion, like let's say a stroke, where someone is paralyzed on one side of their body, there might be just a little bit of disuse atrophy, but it isn't very profound. All right, so atrophy is a profound, obvious feature of lower motor neuron conditions. And then finally, fibrillations and fasciculations. Fasciculations can be seen with any lower motor neuron lesion, again, most classically with an anterior horn cell condition like ALS. Fibrillations you only see in the EMG lab. So if you put a needle in the muscle in a patient that has a lower motor neuron condition, we'll look for fibrillations. Okay, and later on we'll describe and kind of define what is a fibrillation. So I'll just say one word about fasciculations. We've all had fasciculations, and so fasciculations in the absence of weakness are almost always benign. So that eyelid twitch that we've all had, that's a benign fasciculation. But when fasciculations are associated with weakness, now we know we're dealing with lower motor neuron pathology. All right, so our last point here on increased tone. I have a little asterisk here about increased tone. And so spasticity is the upper motor neuron cause of increased tone. And this is what we call velocity dependent. So if you see someone that has a stroke, and maybe their arm is stiff, feels kind of rigid, what you'll notice is if you move it slowly, you may not appreciate that much increased tone, but as soon as you give it a quick jerk, there's a catch, or a spastic catch. And this is what we call velocity dependent increased tone. And that's characteristic of spasticity. And so if you're not sure, check reflexes, check clonus, look for other upper motor neuron findings. So if you're finding hyperreflexia, clonus, Babinski sign, now you know you're dealing with spasticity. And so common causes would be a stroke or cord compression like a myelopathy. Okay, our differential of increased tone would include rigidity. And so now the arm feels stiff, but it's not velocity dependent. So it doesn't matter how fast or slow you move the arm, it's stiff throughout. And so this is generally seen with other types of movement disorders. So a patient will have tremor, other involuntary movements. And so rigidity is something that we see with basal ganglia pathology. So Parkinson's disease would be just one example of something that would cause rigidity. All right, and then finally we can have peritonia, which causes increased tone, but this is different than spasticity or rigidity. Now the patient is resisting you as you're trying to move the muscle. And so this is generally seen with anything that affects the frontal lobes to a widespread degree. And so Alzheimer's would be the most common cause of this. Patient's not purposely doing it, it's kind of a reflex. And so if we see peritonia, we would want to do some cognitive testing. Later on I'll talk about frontal lobe release signs like the glabellar sign and others that we can check. And so peritonia is caused by things that would widespread affect the frontal lobe, like Alzheimer's, or maybe the patient's had multiple strokes, something like that.